Morning friends, I am Dr. Tarun Mittal. We will be talking about laparoscopic management of hepatic hydatid cyst. We did a partial cystopericystectomy. This is a case of a 36-year-old female from Nainital who presented with complaints of upper abdominal discomfort for 2 months. So this is a multiloculated cyst which was present in which they gave the diagnosis of hydatid cyst, in which they could see the daughter cyst also. We got the serology done and it was in the left lobe of the liver, and serology was also positive. So before the surgery, as the serology was positive, we started the patient on albendazole for 1 week, and post-operatively it is required for 2 months. So there are basically 3 scolicidal agents which we have. Hypertonic is the most commonly we use, that is 10 to 20%, and we have to be careful that it can cause sclerosing cholangitis if there is biliary leak. Then others are ethyl alcohol and povidone iodine. So this is a split leg position that is there for all the surgery like fundoplication, bariatric also, or the left lobe of the liver in which we are doing this surgery. So surgeon stands in between the leg. The first assistant is on the right side of the surgeon and left is the camera person. We require generally 3 ports. One is a supraumbilical 5 mm port, which is the camera port. Then there is a right hand working port in the left mid clavicular point, which is 10 mm, and a 5 mm on the right mid clavicular point, that is the left hand work port. So now we generally use 200 gram salt in 1 liter of saline, that is sterilized at 4 degree for 55 minutes. So now we do a diagnostic laparoscopy. You can see this is the gallbladder. Now, as we know, because there can be spillage, we have to use gauze and install hypertonic saline around this area, so that if there is any active scolicidal is there, so that will get killed and will prevent the recurrences. So now we have installed hypertonic saline around this area, and now we will aspirate the cyst, and then we will install the hypertonic saline 10 to 20% and keep it 15 minutes approximately, and then we can repeat it also 2 to 3 times again and again. So after this step which has been done, now we excise the ectocyst which is there, give an incision there, and with the help of the hook, and we should keep endobag besides here only, so that we can put all the germinal membrane and the cyst and the scoliosis just into the endobag. So this is the germinal membrane which we can see. This is the daughter cyst which are seen, and there can be sometimes root capsule, scoliosis, all can be there here. So we have to be patient and just keep on removing this germinal membrane and the scoliosis, and we have to do a partial cystopericystectomy. So we will have to remove whole of this ectocyst right till the normal liver capsule which is there. So here we are incising this ectocyst, and you can use, if there is bleeding, you can use a ligashose. And now we are just excising this ectocyst which is present, and going right till the liver margin. So now all the ectocyst, broad capsule, germinal membrane, scoliosis, this all thing is kept in the endobag, and then it is removed through the endobag from the 10 mm port which we have placed. And now just to close the cavity, we just take a omentum and take a bite from the capsule cavity, so that the cavity gets closed and no fluid gets collected. So this is the material which we have removed, and thank you.